surgery, and that applies to maybe about 30% of patients. These are just graphs showing long-term survival. So again, they have data out to 15 years. This is very similar to what is seen after radical cystectomy up front. The data is very, very similar. And one of the things you'll notice between a radical cystectomy versus this bladder-sparing approach is that after 5 years, very few failures. Meaning, if you get to the 5-year mark, the chances of having a late recurrence are low. It's one of the criticisms of bladder-sparing therapy, since the bladder hasn't been removed. Are you subjecting those patients to a higher risk of a late recurrence later because they still have their bladder? I think it's a fair question, but this data suggests that that may not be the case. It's similar to cystectomy, that if the first 5 years show good results, that's likely to be durable. This shows that the approach works well in the elderly versus less old folks. So the red and blue lines, one is for age over 75 and the other is for under 75. And the results are comparably good. We can skip over this one. This is just breaking up our data. The top line, the red line is the T2 patients, so the muscle invasive. And the bottom blue line is the more advanced patients, those where it's going to the fat or other organs. Obviously, the ones that are more advanced are going to do a little worse than those that are less advanced. That makes sense, and that's true whether you have surgery up front or bladder-sparing therapy. The important thing is that 50% of our patients are not dying of bladder cancer, even with more advanced disease, the blue line. 50% long-term, 15-year good results, and I think that's an important thing to know. This is just breaking up the data by those who had a complete response, the red line, versus those who didn't. It's a very good early indicator of how well you're going to do. Is that cancer sensitive to the treatments we're giving them? If they are, you're more so in the red line group, and if not, in the blue line group. And this, just for background, shows, I mean, many folks have started to talk about neoadjuvant chemo before cystectomy or chemo before bladder-sparing therapy. And there is a lot of good data to suggest that in certain scenarios, chemo before cystectomy can make sense and may lead to better results. And that's still a point of debate, and it's being sorted out. But there's that data. In the world of bladder-sparing therapy, our data shows there is zero difference. Basically, you don't really need to look at the graphs too close, other than the red and the blue are overlapping with it. You can't tell them apart. And so neoadjuvant chemo and bladder-sparing doesn't seem to help. And next slide, please. That's been shown in a number of other studies. Again, the details don't matter so much, other than to say there really isn't any solid evidence suggesting that neoadjuvant chemo before bladder-sparing therapy helps, and so we typically do not do that. I think we can probably skip over this one. Other than, if you go back actually just for 1 second, if you look at the yellow, complete TURBT versus not complete. Basically, long story short, if your urologist is able to have a complete resection up front before you start into chemoradiation, your results are going to be better. That doesn't mean that if you don't have a complete resection, there's some reasons why you can't. It's not just because they didn't do a good job. It's sometimes the tumor is so advanced that without doing serious damage, putting a hole in the bladder, something like that, that a complete resection just can't be done. You still have good results, even if a complete resection can't be done up front, but they're not as good as if you were able to have a complete resection. That's basically what this is telling us. We've developed nomograms, and are you familiar with nomograms? Basically, a bunch of clinical factors to say, well, how well are we going to do? And so we've done that with our data from the Mass General, and these are being made available also to clinicians who are taking care of bladder cancer patients. I think I'm going to emphasize one thing, that selection of patients is key. Bladder-sparing therapy is not really appropriate for all patients with bladder cancer. It is a good option, and it is a very viable option for certain select patients. And who are those patients? Usually those are the patients who have one tumor.